same. Please let me know if you can't hear me at any point, if I need to project a little bit more. But I just want to say thank you, Kaylee, for sharing your story. It's so important for us to ground our care and how we're showing up for each other, and really just like remembering all that we experience in this work. And obviously your story is such a beautiful and happy one, and that we get to be here with you now. But I'm thinking, and Tara and I are tearing up back there as we're listening, because it is so activating and reminds us, I'm sure, all around the room, of so many difficult situations we've been in with patients, and some that don't always have that same ending too. And so I just want to hold space for that for a moment. We're going to do neuro drills in just a second, but if you at any point need to get up, move your body around, do anything to kind of move those out, please feel free to do so. And that's part of what we'll be doing this whole day, this whole hour with me, is really just talking about kind of like refreshing ourselves on the nervous system a little bit, remembering how that works, how that's then showing up in our interactions with each other, with our patients. So our official objectives here. Oh,
You're recording. Can you just drag that up?
oh, yeah.
Yeah, you gotta do that.
Out of the way.
There you go. Just pull it right on up to the top.
There we go. Okay, perfect. Okay. So we're gonna appreciate, right, the importance of perinatal specific trauma, how it shows up and can cause psychological distress. And we're gonna work on fostering these trauma responsive leadership techniques and tools for you all to have. And, you know, that's the official way. Unofficially, like, we're here for you. I'm gonna have some time here for us to discuss together your table, some situations you've run into, and to exchange ideas. I'll share some research back things we've come up with for what staff is asking for, from their leaders. But I really want this to be as interactive as possible. So please feel free to like interject and let me know some of your thoughts or what's coming up for you. Oh, did I mess something up when I moved it maybe?
Let me come up here and see what's happening.
Well, tech support, excuse me. Okay, we'll get tech support in. Okay. I'll move on to the next slide in my head. So I'm here sharing with you because working within birth care has been one of the biggest honors for me. And as we kind of learn to ride those highest of highs with our patients and the lowest of lows, I've also seen how many folks are struggling within birth care. I talk within my work as a nonprofit with clinicians and non-clinician birth workers all across the country who are sharing how difficult this is. And so in seeing this struggle, it's really exciting to be here with you all, right? The leaders who have so much power to create change, to create shifts in unit culture, to provide these resources. And that's what we hear folks asking for, right? When we come and talk to a unit or a group of clinicians coming together, they're like, oh, but I wish my manager was in the room right now, right? I wish that the leaders, I wish the admins were here too, so that they could be getting the same information. So I appreciate all of you taking time out of your very busy schedules and the multiple demands that you have to come and do this together today. Thanks, bud. Okay, is it gonna work, or you're gonna be my magic clicker? Perfect. Okay, so I want to check in, just to get a vibe check for the room. So like, how are you all? How are we all feeling? So excited to be here. Can't imagine anything better. Okay. Overwhelmed. Yep. There's a lot going on. And I also just want to hold space. Like, there is so much going on in the world, country, in our families, in our day-to-day lives. And we're carrying all that into these spaces that we're in too. And so, I invite you throughout this whole time, the whole time today together, but especially in the next half hour or so, thinking about how do you feel like you're connecting with the members of your team, whoever that is, whatever your role is, who you're supporting, right? What do you think they might say about that connection, right? How can we focus on fostering authentic connection? And we'll work through a little bit, because I know for some people, when we talk about changing up how we're relating to each other, right? Adding in some scripting in different ways, it can feel inauthentic, right? It can feel kind of forced and like it's a muscle we have to kind of stretch and practice. And so we'll have a chance to kind of play around with that later too. Okay, so our time together here. So we are gonna be talking about trauma. Obviously, there are no graphic birth stories or images in this presentation. I am gonna be talking about trauma responses, and some of the pitfalls that we see around kind of leadership within that. There's no non-consensual participation, although I will ask you to kind of throw out some ideas that you have if you want to. There's the handout available that Adrian oriented you to follow along with. Please mark it up and then, take it with you and reflect back when you have time and energy to do so later. And we are going to do some neuro drills to open and close. So we'll start with that next. And so with neuro drills or nervous system drills, these are just ways that we're working to kind of calibrate, regulate our nervous system, okay? There are many different ways that we do this. We're going to walk through a couple together. I invite you to try whatever feels good for you. So we'll start by just kind of deepening our breath. Right? So play around for a minute. What does it mean to tune in, right? That's one of those autonomic functions that maybe we all need to give a little bit more attention to regularly. So I invite you to kind of think of your breath. Maybe start to exhale a little bit longer, a little bit deeper. If it's helpful for you to kind of count as you're doing this, sometimes folks like to count up to maybe 4 on the inhale. Maybe exhale out a little bit longer to 7 or 8. You can close your eyes during this if that's comfortable for you, or you can lower your gaze down. And just see how your body's feeling right now in that next step. We all just heard a lot, right, from Kaylee's story. I know that feels activating, right, in our bodies. So as you kind of tune to the next, you can keep doing whatever breath feels good for you. Maybe shaking out your arms a little bit, and just checking with your body. Do you need to roll your shoulders up and back? Is there anything that feels like it's kind of tweaked? Is there any tension you're holding? Do you need to shift your position? Just kind of thinking about how we are co-regulating within this space, right? It's wonderful, and I love, especially in the world of so much Zoom, to be able to be in an actual space together where we can all kind of be working off of each other. Because in the same way, if one of us was running around screaming right now, we'd all be pretty activated. We have this opportunity to all kind of collectively like, okay, really settle in, be present in this space together. And then you can feel free to keep, doing those, whatever feels good. The other one we'll do is havening touch, which is a very basic version. It's just a way of kind of doing like long, slow strokes on our body. It's part of a lot of like psychosomatic therapy work, but it's something we can do to ourselves too. To just kind of, again, like calm everything down. We're letting our bodies know we're safe. You can do it on your face, with like long, slow strokes down if that feels good. You can do it with your hands, right? Generate a little oxytocin, a little comforting touch for ourselves. You can do it up and down your arms. Cross body, right? Which is a lot of cool stuff in our brain, right? Or you can do one at a time. And then just kind of letting ourselves just be here for a moment. Letting go of some other things that we're holding, some personal, professional things that we bring into this space. All right, and then we'll move on together, but obviously, you can come back to those at any point during this. And there's actually a beautiful area right outside here. If anyone needs to take a moment to themselves to kind of collect themselves at any point, you're welcome to step out. Okay, so the embodied trauma-informed care framework is something I've developed in my work with Mandy Irby and Paula Rojas-Landabar, 2 other labor and birth nurses. And this is our kind of framework for looking at how we can provide trauma-informed care to our patients in that work, and then also amongst ourselves, care for ourselves and our colleagues. And note, within this, these are things that we come back to continually. It's not like a check one and you're on to the next. Here today, we're doing this, right, where we're appreciating the implications of trauma experiences, right? We're seeing how it shows up in birth care, in ourselves. We're starting to foster some of those healthy care relationships with our patients. And like we just did, working on fostering our own kind of nervous system practice and coming back to tuning into that more. We're advocating for our patients' voice and choice and their autonomy through birth. And we're also advocating for ourselves, for our staff, right? For us to heal together as we, navigate being in birth care. We're supporting trauma responsive, collaborative, groups. And that's why it's so exciting to be in like a multidisciplinary space like this too, right? Because we know like we are always showing up in interdisciplinary ways for our patients, and we can do that within our units, within, our departments as well. And then finally, debriefing, right? Just like Kaylee mentioned, there's debriefing that we do about care that we provided, right? To see where their system, blocks, where processes that we can improve. And then there's debriefing we need to do for ourselves, right? To check in with ourselves to see how emotionally we're processing. And so all of these things are happening kind of constantly in tandem as we navigate through birth care. Thank you, my clicker. I'm sorry, it's not working. Okay, so defining trauma. We've heard a little bit about that. I use the Substance Abuse and Mental Health and Service Administration definition here. It's an individual experience an event that overwhelms the nervous system's ability to cope and has lasting adverse effects on the individual's functioning and well-being, right? So this is that 3 E's definition, right? We have the bolded words, the experience, the event, and the effects. And this is something that, is true whether we're talking about individual trauma that someone's experienced, generational trauma that happens, vicarious or secondary trauma that we might experience within our work. And the important point here is kind of noting that like, when we're talking about trauma-informed care and trauma-responsive leadership, on the semantics point, sometimes when we're talking about trauma-informed, sometimes those are used interchangeably, but trauma-informed kind of speaks to like that first step, right? Where we have awareness, right? We're growing knowledge. Trauma-responsive is the more action-oriented piece where we're kind of putting all of that into our practice. But when we talk about those, we're trying to move from thinking of trauma-informed care as like an exceptional level of care that's reserved for those special people over there, which is often how we've kind of seen it show up within perinatal spaces. And really looking to see if this is something that like trauma is experienced by all people in all different ways and times, and thinking about how we can really just kind of reorient ourselves to that.
Okay, no, nothing for me, okay.
Perfect, okay, so this is a question we get a lot. How do we know when trauma is bad enough? Right, what counts? What do y'all think? Individualized? Yeah.
Trouble in relationships.
Mm-hmm. Absolutely, right? You're seeing when those symptoms are showing up, right? Okay, so we can go to the next one, Adrienne, and you're right? We don't know, right? We don't decide when trauma is bad enough for someone else, and we don't have to, right? I think that's one of the things we feel like we're worried when we learn about this, that this means, like you said, that we have to become therapists, right? We're not behavioral health experts. We don't have to do that. We don't have to define or diagnose trauma for anyone else. We're just recognizing and trusting the experience of those around us. And, where we're seeing, when we see symptoms of it, we are trusting that that's what we need to, we don't need to know or justify the cause of trauma, but can we respond to what we're seeing show up in our environment? So another little point here around big T and little t trauma, and I'm gonna be very honest, I don't love the distinction between these two, but you may have heard it talked about that way. And so I just want to acknowledge that, one, we have kind of like big T ones maybe on the left here that we kind of typically socio-culturally, we've acknowledged like these are going to be traumatic likely for many people, right? But note that these lists, people could say, they could switch things on this list, right? Some of these that are over on the right that are little T traumas can be perceived as by people as also being big T in their lives, right? So again, just reminding ourselves that like the things that are happening over here, we don't know always the whole story. We don't know how many of these little things are adding up all together. And so just recognizing, kind of broadening our mindset around what is causing trauma and how it's going to show up and how, how impactful it can be. So moving from there, we see this kind of iceberg image in the middle, right? Same idea. Up on top, what we see kind of above the surface, both for patients and staff, are a lot of these kind of expected trauma, right? Like we know, right, a catastrophic postpartum hemorrhage, right? A death of a patient, a baby. We expect those to be, traumatic. We see that NICU stays often for parents, all right? And then there's all these things that are floating below the surface, right? Both for our patients and our staff back and forth, right? Childhood experiences, adverse childhood experiences, or ACEs, things that they're experiencing in their personal life that we may never know about, right? They might not ever disclose that to us, what's happening in those, and they don't need to, right? For us to respond in this trauma-informed way. And is there anything on here that kind of jumps out at you all, something maybe you haven't thought about before, or that you're seeing show up more and more as you're kind of tuning in? It all makes perfect sense. I love that too. Okay, great. Next slide. All right, so when we talk about types of trauma, we see that there's kind of these couple different types. So there's positive stress, right, that we kind of just feel naturally throughout our work, right? And we're gonna have those, like, right, maybe you're having a job interview or you're starting a new role, right? You're going to a big meeting. You're standing up in front of a bunch of perinatal leaders, giving a presentation, right? We're gonna have a little elevation, right, in our stress hormones, right? We're gonna have a little increase in our heart rate, and our body's just kind of naturally prepped and ready for like kind of an exciting stress. Then the next piece is we have kind of tolerable stress. And, we see this coming through where we're expecting that maybe there's something that's been going on for a little bit, right? We know we're going through a tough season, right? Or this is gonna be a difficult month. There's kind of like a deadline that we think is gonna loom, and when we get there, things are gonna settle down a little bit. So we can prepare our system, right? We can lean on our support system, our own coping and resiliency kind of like to get through that and power through something difficult. And then what can happen though is that leads to eventually a toxic level of stress. So perhaps that formerly tolerable stress, maybe that deadline comes and goes and it hasn't changed, right? It's lasting longer than we think. Or our system supports have changed, so we're not as able to cope with it now. Maybe other things have come up along the way. And so all of that is adding, it starts to change how our brain architecture works, right? How we're processing, how we're able to respond to situations. And then there's also kind of like intergenerational trauma. It happens, when we think about the like kind of chronic effects of, racism, genocide, colonialism, all of those things that also start to kind of create epigenetic changes and shift on a cellular level how we're responding and ready to, prepare to navigate trauma. Okay, so one way of thinking about this is the window of tolerance method. So in this, we see, in the middle here, we've got like, we're going down a little river, right? So on the left, we have a small window of tolerance, right? So that's what you think like, oh, the edges are right there. We're worried there's rapids. It's a lot harder to navigate, right? It's much more stressful ride. Whereas over here on the right, we're in our little unicorn floaty. We're having a great time. We have a bigger window of tolerance. We kind of develop that larger window of tolerance when we're taking better care of ourselves when we're really tuned in with our nervous system. We're doing things like listening to music, maybe we're meditating, we're going on walks, we're moving our body in ways that feel good, and we're spending time with, with loved ones, we're doing hobbies we enjoy. All of that kind of increases our ability to deal then when something difficult comes up. What we see is that, we can kind of become dysregulated and out of this when we have that shorter window of tolerance. We can be dysregulated when we start feeling more anxious. We're just feeling out of control and everything's happening like a little bit too fast. There's too much going on. And that can lead kind of up to this hyper aroused state, right? Where we're anxious, we're on edge, every little thing sets us off. We're really we're too much is going on. Also, some people respond to this kind of decreased window of tolerance with dysregulation where they go kind of into that hypo-aroused state, right? So things start to get difficult and we're not feeling comfortable and we start to kind of we're freezing up, right? And we're shutting down and we don't know what to do. We can't seem to find a way out of it. So we can kind of move in either direction out of that. And our goal is always kind of move back into that expanded window of tolerance where we're able to kind of flow with the river a little bit more easily. So, the job of the nervous system, right, is to support us, right? It's to be very quick. It's about making predictions. So our brain is used to it's getting all this input all of the time, right? And it's being able to quickly categorize and say, yep, okay, this is here, this is a threat, this isn't a threat, we're safe, we're not safe. So it's doing that all so quickly without, our conscious thought into it. And so one of the things that happens is that when we perceive a threat, especially if we're in one of those narrow window of tolerance moments, we don't have the ability to consciously think through, is this actually a threat, right? Is this a problem to my nervous system, to me? Right away, we're going to go into one of our stress responses, right? So fight, flight, freeze, and fawn are pretty common ones that we talk about often. There are many others beyond that. Many of us in the room, you might know in a typical stress situation where you go with one of these, right? A lot of us will have one that we kind of lean into, more easily, but we can experience, any of these different ones. And what's important to know with this is that when people are reactivated, right, and they've had past trauma and then they're being brought back into it and they're kind of flashing back to it, that is not like a movie playing in their brain, right? That you just, it comes on and it's happening here and you're watching it and you're okay, now I can just turn that off and be done with it, right? We're experiencing it in our body, right? We feel like we are back there. Our brain is not able to make that distinction between the two. And so we're going to kind of over respond and move back into one of these stress responses. So when we're looking at these different trauma responses, I want you to kind of picture in your work, people that you've dealt with, how can you see these maybe showing up with some of your staff, right? And some of the folks you support. Which ones of these feel hardest for you to navigate? Because we're going to come back around to that a little bit. Okay, so think through which of these responses do you personally, maybe it kind of pushes back against some of your boundaries, right? It might be something that you also move into, so there can be some rub there, but think through this and think about if you're seeing this with any of your staff or which one of these you feel most challenged by. So with that fight response, what's happening with our brain says, you need to fight for control and safety right now. You need to take charge and get control of this situation. And so what that comes out is angry outbursts, right? We're demanding perfection from others. If I could just have everyone do exactly what they're supposed to do in this moment, we would be fine, we'll get out of this, right? And we deal with all sorts of urgent situations. So this one comes up a lot, right? Especially in emergent situations, I see a lot of knowing head nods, right? Most of us can picture someone we work with who swings maybe very easily into this, and it's been very difficult to work with them in a stressful situation because their response is so up here and they're yelling at everyone and they're demanding stuff from people, and everyone else doesn't really know how to kind of respond and just work with it because there's so much going on at once. So those people are often, they're kind of controlling others. They may be blaming everyone else for not giving them that quick enough, and then we'd be through this moment. So we can cause a lot of this, again, now everyone is kind of thrumming up here, even if they weren't before. In flight, so in this one, whether figuratively or literally, our brain is saying, you just got to get out of here. We need to get to safety, and it is not in this moment right here, right? So with that, you can see people who are kind of distracted or disengaged from their care. They might be showing more obvious signs of kind of anxiety or panic. They might literally leave, right? This is that person who there's an emergency happening on the floor. You can't find them. You don't know where they are, right? They literally have stepped away from it because they
Everybody
can't.
knows that.
But everyone knows that person. You're like, are they? Oh, and they're there in the slide closet. What are you doing here, bud? Yeah, we've all been there, right? So that's what their nervous system is telling them, no, we can't be a part of this, right? I need to physically be gone, and that will be better and safer for me, right? So what are ways that we can bring to someone who's experiencing that, right? Bring them a little bit more calm and control within the space, right? That's something we can work on developing, right? And those people also, they can be rushing around, or they can be the perfectionists, the overachievers, right? So they're constantly just going from one thing to the next, trying to okay, just do all that stuff. Freezing, right? So this person, we've gotten dysregulated. We're down that hypo-aroused state where like, we can't think of anything to do, right? We're unable to think through how we can get to control and safety, right? So they might seem spaced out. Remember, they seem to kind of give up quickly. They're not able to make that decision, right? Especially in urgent situations, right? They can't really take action. They're not sure, oh, should we do this? They're wavering back and forth. And that's where so many of our protocols and procedures come in place, right? So when we take some of that out of that, so for people who are feeling like, what do I do? Oh, you're gonna work through this checklist, right? We can walk through that with them. But they might want to hide from problems. These are people who it can be really difficult sometimes to engage in things when things did not go to plan, right? When we need to kind of work through what could have changed, there's gonna be a lot of like reticence to kind of engage in that conversation and figure out what they could do differently. And they're gonna, they might literally be hiding and, appearing overwhelmed. And then fawning. So these are people who we've decided it's safer to just give up control, right? To get to safety. So if I just go along with you, right? My person is fighting at me right now in the situation. If I just say, sure, I'll do whatever you want, that's going to get us through this more easily, right? So these are people-pleasing behaviors, right? They're going along, but maybe they're disengaged, right? So this is where we really need to tune into like body language, right? To tell what's going on, because these people they're codependent, right? They don't have great boundaries. They're easily exploited. They might not speak up for themselves. And this can masquerade as what? A great team player, right? This is person who you say, hey, we need to do this, and they just go like, okay, right? Because they're just going along. They just think if we can just get through this and I just do what you say, we're gonna get there. And I wanted to make a note that especially within perinatal healthcare, where we take care of, so many women in birth, and then we have a very high, as you look around the room, right? We have a highly like women-dominated profession within this space. There's a lot of like kind of sociocultural expectations that have told women for millennia, maybe that it is safer to just kind of, just get a little smaller, go along, get through this moment, and then we can kind of deal with the piece of it. So we have to be aware of how this shows up in our patients, because it's harder for us to recognize when someone is kind of doing this fawning. And so we need to really tune into it, especially amongst our staff and everything, to see like, how are they actually feeling? We need to go kind of beyond the surface to get a little bit deeper. Okay, so as we remember back to maybe a few years ago, last time we kind of thought about our brain and how it's all connected. So we know, kind of at the base of the brain with the brain stem, right? This is where like all those autonomic functions are happening. This is where we're doing all the regulating, right, for our nervous system, right? So that's all happening there. So when we're regulated, then we kind of move up into our limbic system. That's where we're relating, right? Those are all those emotional connections that we're making with folks. And then at the top, the cortex, that's all it does. It's involved in our reasoning and critical thinking and, working through difficult situations. So just keep this in the back of your brain as we go on to the next one. Okay. Perfect. So one note about this is that when we're going to talk through what happens and how we cope with this, right? We all have that same brain development, right? We do not all have the same resources to deal with stress, right? So sometimes when we have this conversation, there can be kind of a weaponization of resiliency and this idea that I know what I can do for this. I know how to regulate my nervous system. I know the system supports I have in place, right? Why isn't everyone able to kind of work in that same way and access those same supports? And so we want to just remember like a couple things, there's a sociological theory around like the weathering hypothesis, right? Which talks about how, for instance, like Black individuals have been exposed to greater chronic stress, right? Due to racism and socioeconomic adversity and healthcare disparities and so many others, so that they have a higher allostatic load on their system. They've had more wear and tear on it, and their body system is going to respond differently to trauma and stress than others who have had less, right? So when we look at these strength-based components, right, and we all, we're always trying to focus on that, right, and coming across really positive and finding the best in, the people that we're working with, we want to think about these in that context, right? What do you have, right? So I ask you to kind of like reflect for a moment here. What do you personally have? What does your resiliency feel like? What kind of coping strategies do you have? Do you have things that you can do when you're experiencing stress? That first response you have when you're going through trauma. How might that be different, right, from folks that you're supporting? What kind of lived and shared identities and experiences might you have or not have? How is that showing up within the space? What are those protective factors? So protective factors, we're thinking kind of like beyond your individual thing. Who are the system supports you have in place? What are the supports you have on your unit, right? Where are the places people can turn when they're starting to feel stressed? When that window of tolerance is shrinking and they're realizing like, oh, I'm not feeling good about going into this. Where can they go? And then that regulated nervous system, right? And that obviously all of us could become, dysregulated and re-regulated several times, throughout a day, and that's normal. So what are there systems for it? And if anyone wants to share, is there anything you have in place now, any wellness programs or anything that kind of help to tune people into that, maybe kind of think a little bit more about their nervous system and how they're working through it?
Mine is walking every day.
Walking, especially outside, right? Connecting,
With my friend. We did a debriefing
Oh,
session
yay.
for an hour to 2 hours while we.
combining all of that together,
She's
right?
not a nurse, but she just gets to listen to everything I have to talk about.
Yeah. Lucky her.
Right, lucky her.
I do one of my meetings with my co-nurse, patient safety quality director, and we walk outside in the garage
Uh-huh.
and we do our work meeting while we walk.
I love that. Yes.
So we're working.
Yeah. Multitasking though, but in a positive way that actually, is meeting
Sometimes
other needs.
We divert in our conversation,
Right.
but
Yeah.
it's a work meeting.
Right, okay. Anyone else? Anything else? Good. Anyone have like yoga practices maybe that are offered at their facility? No, okay, we'll come back, we'll circle back around to that, okay.
Maggie,
Yeah.
one thing I did want to say is, I think for me, to Kaylee's point earlier about compartmentalization, I might be the queen of that. I might own a crown in that area. And I also know that my process for necessarily like managing stressful situations or dealing with it may not necessarily be like the way it's best practice. So I have to be very thoughtful not to like, this was a lot for me when teaching. Like, I knew how I managed things or things that came to me when I was in school. But I have to be really thoughtful not to transfer my way of managing stress onto other people, because everybody manages it so different or reacts so different. So that I think was something that I have to really keep in the front of my mind all the time, because I could easily be like, why are you so stressed out about that? Like, that's not that deep, and I can't be like that.
Yeah.
But your 4 things, the fight, flight, freeze, or fawn, that was just like huge to me, because thinking about new to practice clinicians, like just applying it just in that setting and thinking, we all know there's always the nurse or physician, some that are just like walking around in circles, like, like the sky is falling kind of thing. Some that are hiding, some that are angry. And it was so real. And it's almost like when you have new to practice clinicians, I mean, for anybody, but okay, where do they fall and how do we get them to like acknowledge that and then support them through that? Instead of just being like, why are you hiding in the closet? Like, get out of the closet.
Right.
Like, there's a reason you're hiding in the closet.
Right, yeah, it's kind of getting into like that root cause stuff, right? Like all of this is helping us to connect a little bit more deeply. And I love that you brought that up, because we also all have maladaptive coping strategies, right? Like we've all been exposed to them. Maybe there's some of us who are enlightened around the room who have shed all of those and never go into them. I love that for you. But most of us at a time, right? And we know, right? We know when we're doing that, right? We know when we're just sitting up, we're anxious. We know when we're maybe using substances that in a way that's not supporting us. Like all of those things can come up in us. And we have to be careful about making sure that when we're trying to talk through with someone, we don't accidentally give them a coping strategy that's worked for us, that is in fact not going to be supportive for them, right? Like we have it on slide later, but like what's got us here might not get us there, right? Like all of us are constantly on this journey of learning a little bit more about ourselves and tuning in. I think I'm also a parent, and it comes up constantly in that time too, where I'm realizing like, oh, this is how I always work through this, but hey, that's not actually like a good way to do it. So, all right, we're gonna have to like learn a new way together. And that's what we're doing, with our staff and with our peers too. We're figuring out like, hey, that actually turns out we're all really stressed. We're traumatized. We're not dealing well with this. So what's some new ways we can work into it?
I would share that,
Yeah.
as a nursing director, I go meet with a couple of my chairs. And when I go in their office, both the OB and the P, they both have sofas in their office.
Oh, yeah.
So there are times when I walk in that office, if I'm sitting on the sofa, I'm vomiting something. But if I'm sitting at their table, we're problem solving. So just in the location of where I tend to sit and how I come in will be the presence of the space that we're in for the meeting. And oftentimes I need sofa time. you know?
Oh, I love that.
And so it changes the
Yes.
tone of the space that we're in, even though the location's the same, but just how we approach it is very different.
That is, that is such a great opportunity for all of us, right? To like think through the spaces we have right now. What are the spaces you have on your unit, right? Are there places that feel like they're a little bit more, like you said, we're problem solved, we're getting through this, we're working on it? Are there places that feel a little bit more like, no, we're just coming together to just like get some stuff out, right? That is a great way of thinking through a lot of spaces in my life right now. I love the idea of having the, like that separation within the same room, even where there's kind of a different vibe. That's really, and it's interesting too, because we're gonna talk more in the skids later, but with all of this like trauma responsive leadership, we are not expecting you are not carrying the emotional health of the team on your own shoulders, right? Like that's unrealistic. That will also spiral out you all into a completely different and, not productive sense. So part of it is being able to like set up the culture and to communicate between yourselves what you need, right? So if you as a leader know and you've kind of established, hey, we can have meetings sometimes that are like, yep, we're getting through it. We need to figure this out. We need to solve this. What's the QI project we're taking on for this? How are we going to work through this? Let's look at the policy. And sometimes you're coming in to say like, this has been really hard. Let's work through it. If you've established that there are spaces or times for that, then that also lets people know when they come in to your office and they sit on the couch, that helps you to know, oh, got it. I can put away my problem solving skills and I'm just going to sit down and be in the listening mode and the responding mode. And so thinking about how you can set up that culture within your staff, right? For them to know that they can come to you with both those things and that they can either signal to you in subtle ways like that, but they can say, I need couch time, right? Or whatever your code, like they can say, and we do that, you might do that in your personal relationships, right? Like, with your partner, you're sort of talking through something and you want a solution. And other times you just want to say, it's just really hard. And I just need you to tell me, yeah, that's ridiculous. That's so hard. And then, okay, tomorrow we can get into problem solving. And so sometimes, our staff, they need that too. They need time to just kind of get everything out. So how can we set up spaces for them to know that they can come, right, to discuss those things too? And everything doesn't always have to be in like fix it mode. Anything else on that? Okay, thank you. All right, friends, so we'll do a little playing around here. So if anyone wants to lift up their hand, they can. This is Dr. Dan Siegel's hand model of the brain, right? So we're remembering that image from earlier, right? So down here, we have spinal cord, we're coming up to our brain stem, right? So here is where we're doing kind of, again, all that regulating is happening here. Here, right, we're in like our middle brain. This is our mammal brain, right? We've got the limbic, hippocampus, the amygdala, all that stuff. That's how we're emotionally relating and sharing with folks. And then up here, right, we have like our prefrontal cortex. That's where we're doing all that reasoning and everything, right? So when we are like this, right, this is our brain. Everything's connected, right? Everything's communicating well, everything's taken care of, right? When we get into a stressful situation, we can flip our lid, okay? Now, things are not communicating well, right? We are sitting here, we're flying free with our emotions. Everything's out there, right? All of our anxiety, our fears, this is where those trauma responses are on full display, right? We're not in the space up here where we're able to think critically and come up with a solution and work through that, right? Because we're so disengaged from ourselves. And so when we come into a situation and we're looking to support someone and we're both like this is not going to do it, right? So we think about how do we first, coming down here, right? How do we bring us back to that kind of whole brain thing where we're all connected? So first we're regulating, right? Just like we did today. Is there an opportunity for some neuro drills, right? You see someone who is clearly dysregulated, right? They're all over the place. They are very much not ready to sit down and have like a productive connection or conversation. First, we're going to maybe tune into that, offer some of those opportunities to get ourselves regulated, either together, right? Co-regulating again is very powerful, right? Or to offer, is there a quiet space, right, on your unit that you have for folks to kind of sit in stillness, listen to some music, sit in the massage chair, right? Be still. Once we do that, right, then we're more able to kind of relate again, right? So that's when we're starting to connect, right? That's where we're echoing, right? What's happened, we're saying, I've been here too. We're acknowledging and giving them feedback on, I'm seeing this, I'm hearing this from you. We're doing all that stuff, right? And then once we've done that, we're able to come down, right? Have our lids closed, and then we're able to say, okay, hey, all this has happened. What are our next steps here, right? How do we work through this together? And now this person can engage too, right? Because you kind of help to bring them all back together so they can think a little bit more critically about the issue as well. Now, since we don't all walk around like this, right? Here are some of the other symptoms that we're gonna see from folks, right? When they are feeling dysregulated, right? When their lid's a little flipped. So, and there are, this is not an exhaustive list, obviously, but we see, these big buckets, right? We see some physical symptoms, we see cognitive symptoms, emotional ones and behavioral ones too. So, when we're thinking physical, right, people can go into those hypo-aroused or hyper-aroused, symptoms. So with that, we can see some pain, we can see some somatic complaints, right? And you might think on people on your unit, right? Do you have those people who kind of perpetually are calling out, right? There's always kind of just something is a little off. Obviously, can those be, medical issues that they're dealing with? Sure, but is there something else going on there where that's, the body keeps a score and all that? Are they having headaches all the time because of stress they're feeling from work that aren't being, addressed? There's all of that going on. There's the cognitive stuff, right? Not being able to concentrate, memory problems, intrusive thoughts, maybe problems sleeping, nightmares. Some of the emotional stuff that we start to see, right? People who suddenly are detached, right? And these can often be, workers who up till now, they've always been really, they're those team players, they're really involved in everything they're always doing. Sometimes, all of a sudden they're kind of isolating themselves. Maybe they're isolating themselves from hobbies, from loved ones, things they'd like to do. You're starting to hear like fear, right, around work, beyond the usual kind of tension we all hold for, potential emergencies. Like they're really scared to go in. They don't feel like they can show up the same way that they always had. They're having a lot of guilt or shame about what's going on. And then the behavioral stuff. And, this is tricky. We see, we know in, a lot of clinicians, we experience higher rates of substance use disorder, right, than other professions do. We know that when people are trying to seek control, right, if they can't get it, otherwise they can slip into like disordered eating, right, other compulsive behaviors, because that gives them control, right, over something else when so many other things are feeling out of control for them. And looking to see kind of what's happening in that interpersonal relationship, right? All of a sudden, there's constant issues, right? They can't get along, the assignment's never right, they're being, like rude or insensitive with patients, right? They don't really keeping up with the bedside manner we expect, and other kind of anger-related issues. So when we remember back to our 4 R's, right, that Adrian went over with us, when you think of where you all are on, right, in your application of the 4 R's, right? So you realize the importance of trauma-informed care and trauma-responsive leadership because you're here. So great, check, right? We're recognizing these symptoms together. And I'm sure most of what I've, provided today is just a refresher, right? We've heard about these before. We're trying to kind of contextualize them and put them into this. So we know kind of what to look out for now. And so now it's this place where how are we going to respond to this, right? What tools do we have to show up and support folks when they're experiencing this so that collectively we're ready to resist re-traumatization, right? And this is something, like we said, that has to be happening back and forth with those that we're supporting. This is not something just a task for you all to take on. So let's think through these 6 key principles. And I'd love it, as we're thinking of this in context, right, for your staff, right? Picture a couple of folks that you work with regularly, right? Picture anyone who you've been kind of struggling maybe to support and was having a harder time. How can these principles come together, right? And we want to think of these are always, again, it's always driven by the people who we're, supporting and working with. What are some of the safety things that they might need? There's like the physical piece, right? So, sure, that goes from like the units we work, right? There's good lighting in the parking garage. There's adequate resources and supplies on the unit for them to do their jobs, all that. There's psychological safety, sure. And that's obviously a much harder one sometimes to establish, especially when we have a lot of turnover, right, on our units like we were talking about. And that's a self-fulfilling kind of issue, right? Because then we have a lot of turnover and it's hard and things are difficult and we have more turnover, right? So how do we kind of get that unit culture in a place where we have trustworthiness consistently, right? Where folks know that they can come and discuss these and that it's going to be met with understanding and appreciation and not dismissed. And that's hard when it hasn't always been, the culture, or when people are coming from different units, right? That is not allowed, right? That people don't kind of talk about that. There's a lot of integration that has to happen, within the staff to make this feel safe for everyone. What else comes up on here for anyone? Anything jump out? Yeah.
I think sometimes we forget that we as leaders need to come with humility, not to set a table or an expectation for perfection or that we're not fallible.
Yeah.
And that can, so by presenting with humility, coming with humility, we allow our staff to speak up, to feel comfortable that we're on the same page there.
Yeah. That's such a good one. And it really is like, I echoing it because I think it's so powerful. And I think we forget that, right? Because we're all human too, right? That's the problem. So, we're bringing our own insecurities into it, right? And so many of us have been trained, right? And we have so much hierarchy within healthcare, right? That like we have to be that confident leader, right? Who knows everything and is coming in and you're not going to question them, right? And I think that's shifting, right? Like I think there's been a lot of changes over the last couple of decades, but it's still there to a level, right? Where it's hard to be honest about that. And I think when you can come in like with that humility and where you're just being open, right? Hey, I'm seeing this issue on the unit. I'm hearing this, right? I'm hearing you're saying this and you're saying this. I don't know what we need to do to fix that. Here are some options I know about, right? Like you're engaging in this, just that back and forth, that things aren't prescriptive, right? Like that opens up so much of that communication though for folks to know that they can say, that's a terrible idea. Or no, that won't work here, or we'd be really uncomfortable doing that. It opens it up to then have that, everything's more collaborative, right? We're disrupting some of those power dynamics that can exist within our healthcare systems, where folks, especially folks who are newer, right, or less experienced, don't feel like they have a voice at the table and they're not able to kind of step up and share that. So thank you. Yeah.
Along the lines of cultural and historical gender is generational.
Mhm.
As leaders, how we approach making that connection is very different from the generations that we see. And the way if your department has multiple generations, how you lead them is challenging.
Oh, that's
Just-
such a good one.
Just yesterday, this hits because just yesterday I was at the National Association for Healthcare Quality Conference, so it was virtual. And they had a whole hour-long presentation, live session on how to work with the generations and the workplace. And they had this woman present on the things you need to do to engage the different generations in work. And then, and even questions, like people ask questions like, I have someone that's in the boomer generation, but they don't know how to download a PDF or do this. Like, how do I set the expectation that you need to be able to do this? But not, and then, the Gen Z are getting mad or whatever because the boomer can't download this. And they were all talking about like how they deal with this. But I think that's a great point because it's not a one size fits all strategy, but it does tie
Right.
to, I think the mutuality, collaboration. They talked about pairing people up. That was another thing. That was one of the suggestions, like put a Gen Z and a boomer together to work, or a millennial and a boomer together, like they would help each other balance out and learn from each other. But the humility, ties to me with safety and the cultural and historical and gender issues, because when I was doing the research on the safety part, it said setting clear expectations. And that really resonated with me because when teaching, a lot of this stuff would come out. A student doesn't do well on the test, or a student is performing really poorly in the clinical setting. You're like, what is going, we've had this conversation 9,000 times. But then when you sit down and you actually get to talk to them, they come forward and they tell you a story that you're almost can't even, it's not a lie. It's their actual life. This is what's happening in their life. I still can remember this story of someone who had a domestic violence situation. Her electricity had been turned off. I still talk to her to this day, probably 5 years later. But that, I wouldn't have known that story of hers unless we sat down at a table, she shared, and then setting clear expectations. The expectation is isn't that she just is I'm gonna give her 100 on every test. That's not the expectation.
Right.
But how can we work together to set a clear expectation on what you need to do to be successful in the clinical space? And then she knows what she needs to do, and I know what's safe. So I think it's these 6 key principles to me really tied to safety, because it's not about just saying everybody gets a free pass on everything just because you're having you have experienced trauma. That's
Right.
not it. It's about sitting down and understanding how we need to charge this path forward and understanding individual issues.
Absolutely. And I think that's a perfect transition to our next slide,
There you
Adrian.
go,
Thanks for
perfect. There you
keying
go.
that up. We're missing out. Okay. So, but it's great because I think it's hard, there's a couple of things misconceptions, right, that we've had. And one is, we're not just focusing on negative events, right? We are not, by talking about trauma and the prevalence of trauma, we're not creating more trauma, we're not talking it into being, right? So you don't have to worry that bringing up symptoms that you're seeing in folks is going to cause something else to happen, right? We're opening, we're getting rid of stigma, right? We're just bringing it up. And, it's not an excuse or justification for unacceptable behavior, right? it's about digging a little bit deeper, right? Going beyond the surface so that we can hopefully get to that root cause, figure out, heal what's going on there, provide supports, that's right, get additional resources for that person. So then together, we're coming up with those next steps to realign, to get back on with expectations. You know, it's not about just being nicer, right? You've heard, nice is not kind and all that stuff, but, trauma-informed care, it's not about treating everyone the same, right? It's about treating people individually for what they need, for the complex issues that are happening with their lives, and that ebb and flow, right? You might have someone who they're usually the rock star of the unit, they're always doing X, Y, and Z. They're going through something, right? Something happened at work, something happened at home, and they need you to take a little bit off their plate, right? Not forever necessarily, right? But you're looking to really customize how you're relating and what the expectations are for each person. And obviously, it's not just about like doing one training, then like we're done, right? None of us we've never arrived, at some mythical self-actualized part where we know all this, right? It's about continually iterating on this in our own lives and, with everyone we're supporting to see what's working, right? To figure out, to seek more resources and to, respond to the situation. Okay, and then on that note, I want to just provide that we know that trauma is an inevitable part of, our workforce, right? There are always going to be situations that come up. We work with, folks going through birth, and there are the unexpected, right, that can come up. What we want to try to work on is preventing some of the kind of the expected things that we know can cause trauma by providing better system support, right? So on the left, we see like secondary trauma, stress prevention, right? So we're providing trainings, right? We're destigmatizing, right? We're making sure our staff know what's going on, that they can start to recognize some of their own stress responses, right? So that then they can take action on that, right? That's not meant to like bring anyone down. It's just raising awareness for it. So we can do that. We can have regular meetings, right? Where we talk through and address different feelings, right? If you have maybe you have a long-term difficult patient, right? Who everyone's struggling to deal with, or maybe you're having a couple different situations that are coming up. How can they engage with support to figure out how do I work through that situation in a different way that's not going to be so activating for me? And, we're encouraging and, offering wellness programs, right? To widen that window of tolerance, right? To make sure people have resources, not just at home and in their personal life, but, on the unit and with our support. And then we're noting again, post-traumatic stress disorder is not an automatic, fallout of someone who's had a trauma response, right? That is a separate issue that really is an acute stress disorder that needs to be addressed, with other professional help. Again, we're not expecting you all to become, therapists. You do not have to diagnose or do anything like that. But if you're starting to see more severe symptoms for someone, right, they're lasting longer, they're having those nightmares, avoidant habits, right, negative thoughts, they're having hyperarousal, right, or you're worried that they're physically not safe, right, that's when they really need to have maybe a little bit more of a prescriptive approach about making sure that they're getting extra help, that they're getting hooked up to resources where, you're getting employee assistance involved and that they know where to kind of turn if things have become more serious. Okay, and so, like we said, what got us here might not get us here. What folks ask for in the literature, right, is for their leaders to hear me, protect me, prepare me, support me, and care for me, right? Which is hard. That's a lot of things that we're all expected to do. And that's that piece where we can really be collaborating and coming together for that so that everyone's needs are met. Okay, so we're gonna walk through this and then we'll have a few minutes at your table to kind of break up for this last little bit, but I want us to think about some challenging behaviors, start brainstorming. What's a challenging, maybe a common challenging or a unique challenging one that you're having lately that we could talk through, right? So for instance, maybe you're having a behavior, right? You have a nurse, a clinician who's kind of snapping at patients, right? They're really short tempered, right? They yell, you will not talk to me like that. I'll not tolerate your behavior, right? So the first story we assume here. Oh, sorry. Thank you, ma'am. Sorry, this is gonna be a quick one, okay? Get your clicker
When
finger
the
ready.
presenter yells at you.
So maybe they're unprofessional, right? They're difficult to work with, right? Maybe they need to be on medication, right? You're kind of just like putting them off into a box, right? But what we know about trauma, right? Staff are trauma survivors themselves, right? They're processing and going through difficult things, right? And that can impact how they're regulating their emotions and coping with stress. So when we use our key principles, right? How can we establish safety, right? Both for the patient, right? And for that nurse, right? How can we check in to identify some of those stressors? How can we get some peer support maybe? And how can we empower them, right? How can we help them to maybe get into a training around communication or trauma-informed care to help to give them more resources to draw from so that they feel ready to do that? And how do we get more, consistent expectations? Because ultimately we're working on strength and capacity building, right? We're hoping to give them more tools to widen that window of tolerance so that they're better able to deal with these ebbs and flows in our work. Okay, and now we'll have an opportunity. There is We're gonna go to this, no, but and we'll have to all exit out of this for a second, but if you all can go to menti.com, menti.com. And you don't have to do it, but this is anonymous, and this can just be a way, if you can think of one of those challenging behaviors. So when you go to menti.com, you're gonna put in this code, 35765956.
You got it?
Okay. So when you're on Menti, you put in that code, these do not have to be like complete sentences or anything, right? You don't have to identify anything, but just throw up, what's been a challenge for you lately? Oh, 35765956, right at the top of the screen there.
35765956.
Lack of accountability, oof. Resistance to change. Unprofessional behavior, burnout. Yep, accountability coming up again. Staff calls due to burnout, complaining, judgmental patience, yeah. Not completing tasks, yelling at staff for not getting it right. Response seems out of proportion to the situation, yes. That's such a big one. Providers overly confident, bullying, dissatisfaction. There's a lot, right, that we're holding and walking through with our staff. Your frustration with change is so angry. Well, that's so hard to work through. Yep. Avoidance behavior with a difficult patient, gossiping, accountability, scheduling requirements, entitlement. It's really hard. Pointing fingers across the unit. Yeah. Okay. So I'm seeing some of those behaviors we talked about, some of those trauma responses coming up in here, right? Anyone else? Okay. So now we have a couple of minutes in your little workbook from me. There's a space if you want to take notes, but if you around your table, and feel free to keep putting things in if anything's coming up for you. If you want to pick one, you can just decide on the table or pick one of these issues that you're seeing coming up and kind of walk through that framework we did, right? What's that behavior we're seeing, right? It's a lack of accountability. So the story we assume is, right? So feel free to kind of chat through that just for a few minutes and see, how can you maybe apply some of these principles to that issue? And I'll be here if you want to shout anything out.
Challenging behaviors you're seeing and how you might apply some of these techniques.
Yeah, on the back page, we have those little graphics worked out there for you. So thinking about what we know about trauma, what we're seeing from those trauma responses. What are some of those principles from Sam so we could apply to the situation?
Which one you want to do?
Pick a hard one. Y'all seem like you're ready for a challenge.
You're polarizing them.
I don't want it, it's just, I want it to stay. It's so big.
It's because they.
Yeah, and it has to do with so because. And so. So there was a staffing. And then there
Unprofessional conduct.
and then so.
Setting up. That's really like.
Yeah.
But now you don't even set them that and make transformative, right? They more information. So then the trauma piece is like the. And these things are, I Right. We couldn't find that really. The nurses really against it, like. Situation. And. With that. So now I had a conversation.
About a minute left, if you want to get anything else off your chest.
And the, so the story is. The story is that there's a sharing and all that. They're just not listening. They don't work.
I so like, yeah, so that's what, how do you?
And it's rare.
I would out. I would try to think of a provider. So, you know, and from my perspective, I mean,
All right, y'all. I hate to interrupt such great conversation. We'll have more time to chat at lunch. I promise that's right after me, okay? As we wrap this up, I just want to also empower and remind you all that there's a great business case for trauma-informed leadership and trauma-responsive leadership, right? So if you are the budgetary person, there's lots of great data around how it, increases productivity, right, for our staff, decreases that turnover and absenteeism, right? We have better organizational health, right? We have greater staff and patient satisfaction, which is ultimately, right, what it's all about in healthcare. But there is a lot of great evidence showing that this works, showing that we get those financial, incentives and improvements on the back end as well. And then these are also listed out on the back of your handout, but this is what the research is really telling us. In a recent study, 70% of the respondents identified these as the top 8 things that they would like to have access to, right? Not that they would want to use it every time or all the time, but they would like to be able to get these, right? Have some of those wellness programs, right? Have some education on trauma, break the silence on obstetric violence and mistreatment, normalize debriefings, destigmatize counseling, have extra days off following a trauma, extra staff resources, and have a peaceful area to regulate and recover on the unit or in the department. So your exciting challenge is to think through, right? What do you have already? Okay, and I suspect, again, there's some, right? We probably have some of those already, right, that you all have access to. So how can you maybe increase the awareness of them, right? In the next few weeks, right? Can you do a check-in with your staff, right? What of those, because obviously this doesn't happen overnight, right? What's the first thing that they would like you to work on from that list? What would they find most valuable about that they would really like to see come in to best support them, right? And then, obviously over the next coming months, right? What's that implementation process? How can we get the staff involved in that and active in creating some of that change with us? All right, and we're done. You've made it to lunch, okay? So I invite us to just do a last neuro drill here together. So pick maybe your favorite thing that we did to start or a different one if you didn't have a chance, right? And let's just close this up, shake our bodies out. Maybe take some of those big deep breaths, right? And get ourselves all re-regulated as we head out into lunch.
And I just wanted to mention in your folder, you do have a list, and this kind of crosses over between Maggie's presentation and Tara's. There is a list of like some other therapy, peer support resources. I know that your organizations have varying levels, like some of you have RISE really well implemented, or you have an EAP that's really well developed. But in addition to that, we gave you a little list of some online spaces as well.
Right on
And
time,
then the
friends.
other thing that I would just mention related to the intersection of kind of Maggie's presentation and like just your team's safety culture is that one of the parts of the safety attitudes questionnaire is actually on stress recognition. So there's a whole section of the safety attitudes questionnaire that asks, you know, are you aware that when you've basically experienced a trauma, that you are under considerable stress and that could impact the way that you function? And so as a lowest hanging fruit, one of the things that I think is fairly easy to go back to do is talk to your staff to get them through that first R of realizing the impact of trauma on everyone and the impact of a trauma on their work and stress on their ability to provide safe patient care. And then even these things like these neuro drills, I'm sure there's lots of resources online
Oh, gosh,
that you could take back to do at your staff meeting for a short period of time, like in the beginning or the end. And you know, those are just some tangible things that you might be able to take back and do without too much of like additional resources.
Yeah. All right, and then the last thing is I appreciate you, this is not mandatory, but I appreciate if y'all want to give me any feedback on here, it just helps me as I work to, you know, change this presentation the next time I do it, any things you love, things you didn't love, anything you'd want to see changed. I do not have an active email list. It's gonna ask for your email. I will not spam you with, you know, questions. But if there's anything, you know, you want me to know, that's really helpful. And if you complete that at the end, you're gonna get like a little, QR code to like download and share with your unit. It has a bunch of podcasts, from the podcast that we ran with my organization that talk about trauma-informed care on labor and delivery and how they can bring that in. So a little take home for you. So thank you all so much.